Ahmad and I'll be talking about the background and relevant anatomy.
Hi, I'm Rekha.
I'm Shannon.
We're talking about the design of the drug-eluting stent.
This includes how does it work, materials used, and unique features.
I'm Charlie and I'll be talking about benefits and limitations.
Hi, I'm Matt and I'll be talking about future developments.
Bare metal stents were the first stents introduced in the 1990s, but over the years advanced technology and greater knowledge about materials and the human body has led to the development of drug-eluting stents. But what do these stents do? Well, drug-eluting stents are small mesh-like scaffolds made from biocompatible materials. Their main function is to prevent restenosis, which, as we can see in the image on the left, is a narrowing of blood vessels due to the buildup of plaque or scar tissue. This buildup restricts the flow of blood, causing severe problems in the individual. The image on the right shows how drug-eluting stents are coated with a time-release drug that interferes with the growth of scar tissue by slowly releasing the drug to the inner linings of the artery. This proved to be a huge positive when compared to the bare metal stents, as with bare metal stents, restenosis continued to occur, creating huge health concerns and as well as financial concerns for the patients. The fact that drug-eluting stents presented a solution to this common problem of restenosis and its reoccurrence, they became very popular for use amongst patients with coronary heart disease. Stents operate within the vascular system, which is responsible for distributing blood to muscles and organs. Drug-eluting stents are generally used on patients dealing with arteriosclerosis, in which the accumulation of plaque makes it harder for blood to travel, as we can see in the image on the left. Arteries need to be wide enough to allow for smooth and sufficient blood flow, and impeding this flow is most likely to be fatal as it can cause organs to die. If this occurs, the individual can experience a stroke or even die. If this affects the coronary arteries, then this can lead to coronary artery disease, more commonly known as CAD. This is in fact the leading cause of death in the US. If someone suffering from CAD, the arteries will have narrowed, causing insufficient blood to flow to the heart. Drug-eluting stents can be used here as they maintain a sufficient blood flow and hold the artery open for a longer period of time.
Patients who receive a drug-eluting stent are most likely to have it done via balloon angioplasty, where a catheter is inserted into the artery. At the top of the catheter is a small balloon as seen in image 1. This is inflated once the balloon has reached the plank build-up site, pushing the plank against the artery and creating a better blood flow. However, this does not completely stop the restenosis and does not work if the plank build-up is high. A drug-eluting stent is attached to the catheter in these circumstances. We will now talk about the stages of drug-eluting stent implantation. As shown in Part A, there is a restricted blood flow. As seen here, there is a buildup of plaque occurs at the artery walls, which prevents efficient blood flow. At Part B, a stent is then implanted, which essentially compresses the plaque against the artery walls. At Part C, the anti-proliferative medicine is then released from the stent. This helps keep the artery unembedded, allowing for improved blood flow. There are three main components comprising the drug-eluting stent. These are the scaffold, coating, and the anti-proliferative drug. This can be seen in the cross-section below. First, we'll talk about the scaffold. The scaffold is essentially what holds the stent together and needs to be made from a biocompatible material. This is so that it doesn't harm the immune response, cause allergies, or inflammation. The scaffold is usually made from a metal alloy. This may be cobalt chrome, gold, or titanium. The most common metal used, however, is cobalt chrome. This is because it is very strong and resilient, hence the stents can be made thinner. Another important feature that the scaffold must have is that it has a mesh-like design and it is flexible, so that it can expand within the arteries.
The coating is made from a biodegradable polymer and is located between the scaffold and where the drug is held. The coating is comprised of 3 layers. The first layer is the attachment layer. The second is where the drug is held. And finally, the third layer is where the drug is slowly released. When the coating is in contact with the arterial wall, the drug is released and the coating will soon start to degrade. Finally, the anti-proliferative drug needs to suppress the restenosis to clear the blood vessel for efficient blood flow. The drug is usually released after 30 to 45 days of implantation. This is because it coincides when the greatest amount of cell proliferation is occurring. This maximizes the effect of the medication. For example, the Taxus stent releases paclitaxel in the coronary and peripheral arteries. Likewise, the Cypher stent releases sirolimus to prevent restenosis. The design of the drug-eluting stent is unique as it is the most known effective method in providing long-term and fast improvement in blood flow. This can be compared to coronary artery bypass grafting, where surgeons remove the artery from the patient's body, and this is then grafted, creating a new path for the blood to flow, as seen here. This raises many concerns, including the chance of the patient experiencing a heart attack during the procedure. There are also concerns after the procedure, including internal bleeding, swelling, and the formation of more blood clots. The drug-eluting stent, however, decreases these risks and the implantation is less invasive. This is because their small design, as seen in these images, fits easily into arteries of different sizes, increasing the chance of functioning and survival for the patient. This also allows it to be implanted into all patients, including children. Another unique feature is that there are so many different types of polymers being developed, which may be better coating devices.
In the medium to long term, drug-eluting stents are the best performing variation of stents. Compared with the bare metal ones, the reduced rate of restenosis occurring is significant enough to make them the go-to option. You can see in the diagram on the right the severe effects of restenosis. Stents like this often cannot be removed, so avoiding this situation is incredibly helpful. And drug-eluting stents themselves offer a 5 to 10% reduction in occurrences of restenosis. The procedure for placing stents is also a much less invasive affair than bypass surgery. The incision made is the size of the diameter of a needle, and patients can be discharged from hospital the next day. Surgery, on the other hand, has a 6-week recovery time and leaves patients with large scars. So in cases involving 1 to 2 blockages, drug-eluting stents appear to be the best option. In more serious blockages, however, surgical intervention and bypass surgery is really the only option. Stents cost around $10,000 to $40,000 each, so it's not financially feasible to plant many stents at one time. By the numbers, surgery is also the safer option. Each time a stent is placed, complications can arise. There is a 30% chance that a stented patient will be undergoing angioplasty within 12 months of the first operation. They also do carry a higher risk of causing heart attacks and death than their bare metal counterparts after 6 months. Patients will need to be on antiplatelet drugs for 6 months following the surgery to reduce the chance of clot formation, and they will be on aspirins for life. These all carry additional costs and risk with side effects, whereas surgery is mostly a one-and-done procedure. Stents are an ongoing saga.
The priority of modern drug-eluting stents is to minimize or completely remove risks and possible harmful defects, whilst maintaining and improving an ability to deliver. Newer designs have consistently become increasingly functional and durable, leading to more effective treatment of coronary diseases. Materials and dimensions were chosen based on the desirable characteristics of minimal elastic recoil, conformability, visibility, and ease of delivery. A suitable alloy, platinum chromium, was recently introduced, which offers high yield strength and reduced weight. Moreover, a thinner strut is an important method of reducing angiographic and clinical restenosis. It also minimizes crossing profile, which significantly improves deliverability. Given these specifications are changed, drug-eluting stents will become more beneficial to patients in the future. Many of the design aims can be attained through minute changes in the design process as well as materials utilized. Small alterations in alloy composition, strut thickness, and overall geometry can be combined to improve stent deliverability. Furthermore, research into suitable metals such as the most recent platinum chromium alloy will lead to improved strength, durability, and positioning. Future prospects of drug-eluting stents can be achieved based on the impacts and resolve of these changes.